include Farhiya Mohammed, Lori Zoellner, and Mohamed Roble. So I'm going to provide a brief bio, and then they can come up and share their presentation with us. So Farhiya Mohammed is the Executive Director of the Somali Family Safety Task Force. She is a well-respected leader in the Somali mental health community and bridging different service barriers. Dr. Lori Zoellner is a professor at the University of Washington. She's a well-respected clinician and researcher, and she's published extensively on PTSD treatment. Her research focuses on 3 questions across 3 main areas of inquiry, including information processing mechanisms associated with trauma exposure, prevention of chronic psychopathology following trauma exposure, and interventions for chronic psychopathology following trauma exposure. Finally, Mohamed Roble, who was born and raised in Somalia for over 20 years. He's been working with the Seattle Public Schools, and he's been serving multiple roles supporting students, families, and communities. He completed his bachelor's degree in animal science from Somalia National University and has a master's degree in education and counseling from Antioch University in Seattle. So let's welcome our speakers up.
Assalamu alaikum. I'm Farhiya Mohammed, originally from Somalia. So today we are talking about the Islamic trauma healing, which also this our menu is called Islamul Qulub. So our Somalis 100% are Muslim, so we use it to use the masjid and then to show to Kaaba. So the program it will increase their interest in. So how we use it, it's that way. So, oh, okay. Yeah, okay. A Somali culture profile intersection between faith and the culture and the mental health perspective. Because Somalis, we don't have even any word for the mental health. Either you are crazy or fine. So it's like the mental health, if you have it, if you say, oh, we can do to the counseling for mental health, oh, I'm not crazy. So what do you think about the counseling or the trauma? All that, we don't have it, same like domestic violence. So it's really tough in my community to talk about mental health issues. And what's the war seeking refugees, the Somalis, I don't know if you guys know mostly or not. So since the 1990s, we have a civil war. And Somalia located also East Africa. So there's like conflict between 1990s, 91. So it's like we came here to the United States. First wave of the immigration people, they started to come in 1992 in the US. So the Somalis, like a lot of people, they sponsored for the refugee volaks. Some of them, the relatives sponsored after that. But we are here like 2002 to 2017. The Somalis, like 104 refugees in the US. And then the more than like 1 million flee to different neighborhoods, like Ethiopia, Kenya. Some of them, they went to Yemen, so that's how we flee. And then more than 2 million we displaced in like our countries. But like Somalia is not that big. We are like state of the Texas, whole countries. So the mental health overview in Somalia, like when we had the civil war, you have the life, you have house, you have a work, everything you have it, but you end up refugee camp. So that one, like your stress and anxiety is growing. It's really hard for like the physical risks, because some of them like they get beaten, some of them in front of them, their family they get killed. So it's really hard, like post immigration difficulties. So then like association also psychological distress, depression and anxiety, post-traumatic stress disorder. So all of like, you born in the city, you have clean water, everything, but then now you don't have anything. So everything will change. And then so many people, they will become mentally ill or is the depression to be to refugee camp. So our mental health view into like also community, it is really hard because like either like insane or insane. It's stigma. As I told you earlier, we don't have any word for the mental health. But like, if you say, oh, I have like mental health or I am sick, some people, they label it. So the weak-minded, they label it for like saying, oh, she's talking about the mental issue. She's crazy. What she's saying? Like mental health, you have to be mentally institute. What are you talking about? So social isolation, the people who have it, like the mental health or depression, they stay out of the community members. So then like the suicide is like now our youth is happening a lot of the suicidal in like Seattle and the Minnesota. That's those places I know. A lot of the Somali youth who the suicide themselves. Even though we are really strong when it comes to our religion, but still youth is the youth who is like suicidal. And the mental health treatment is really hard to the role of the religions. And the religions become like, if you see to someone who have mental health, you have to go for the mosque. You have to call to shifts. Otherwise, like the people, they think about, oh, I'm going to see to the doctor or medicine. It's totally different stigma. That's where it came to. So the people, they change it. Like, but like they go, oh, you have jinn. And then to like shaitan is visiting you. So that kind of what we use a lot of like traditional methods of the healings. Especially the women, they have it like, I don't know if some of you guys know to Zab. They do that one, yes, like, so you know that one, and then like, there's some ayah, some people, they provide to the, so to a ruqiyah. They say, oh, read to the ruqiyah, so your jinn or shaitan will go away. But like they are not westernized medicine to use it for our families. It's really hard to, because the barrier of service utilization is really hard. Community, they don't know, the stigma and the fear being leveled. Discomfort, burst. So all these things, as I mentioned earlier, it's like that's the hats we wear as a community. But like the services, also we like learn it to Western things, so we have to like combine it, religion and Westerns. Our like the manual we are using for like to educate our people. Also, all services we have it, we do based on the mosque, which later on the Mohammed and the Lord they will talk. But like we do for the mosque. If you do to outside or other community centers, people they will run. So it's different of the mental health disorders. And then some of them, what is the call economic, because of some of them, like who is doctor, who can this country, who don't speak the language. It's really hard for the mental health disorder. Lack of transportation, many the single mothers, Somalis, who are large families, if you have 10 children, 8 children, you don't have car. It's really hard to go to hospital places because you don't have anybody, and then you don't speak the language. So all your anxiety and depression is growing. So it's really hard for many of the single mothers and the child care also. If you don't have a child care, how you can go to seek for the health services? Islamic trauma healing of cultural informed program to treatment wounds of the trauma. So now Dr. Lear will come to talk more about how we become for our menu, and then we do also every Saturdays to section women and section men. So she will talk more about what our findings and then how we are dealing with this.
All right, thank you everyone. This has truly been a partnership with the Somali Family Safety Task Force, with Farhiya as Executive Director, and also the Somali community and the Somali community leaders. And so Mohamed Roble is representing the Somali community for us as well. One of the things that we know at this point in time is that there are effective interventions for the treatment of PTSD. And this is 2 meta-analyses. First things that you want to look and see, 112 randomized controlled trials for the treatment of PTSD. 64 of those are psychotherapy trials. So we're at a base where we actually have good knowledge about what can be done to help treat post-traumatic stress disorder. And one of the most evidence-based treatments is cognitive behavioral therapy, particularly exposure-based treatments. And what you see here is you see that there are large effect sizes for PTSD symptoms, loss of diagnosis, and also for depression. And the strength of the evidence compared to the other therapies that are out there are actually fairly high. When we're talking about CBT exposure, typically we're talking about prolonged exposure is the type of therapy that we're talking about. When over the last 20 years or so, there's been good research looking at what is the mechanism of action for exposure-based therapies. And 2 of the things that keep coming up in the literature are the role of addressing avoidance of trauma reminders and also altering unhelpful negative cognitions. And so when we were talking and starting to work with the Somali community, these were 2 of the processes that we really wanted to target from a scientific standpoint in terms of things that drive change in PTSD treatment. And so these are really our goals with the program. What makes the program unique, though, is the combination of bringing the science and Islam together. And the idea very much is to reduce the stigma about the impact of trauma, recognizing that trauma is pervasive within the community. And we're not talking about the program as a psychotherapy, we're not talking about the program as a treatment, or for PTSD or for depression, but really normalizing that a number of people in the community have been trauma exposed, and there's a pervasive impact of that. The groups that are held are led by community leaders at local mosques. And the goals are very much trauma healing and also reconciliation within the community. And so the mosque was a logical center to base the program, as it's the drawing place, the community place, the hub for the community. And the 2 key Islamic principles that we pulled on are examination in the lives of the prophets. And the prophets are there to give us a sense of suffering and the role of trauma and the role of faith and the role of discrimination. And so the program relies heavily on each session talking about specific lives of specific program prophets, and also has an individual time during each session for very specific turning to Allah and dua about trauma. And I'll tell you a little bit more about that. The group leaders are leaders in the community. We're using a trainer's model, which means that the university is hoping to work themselves out of a job. With group leaders, we're looking for folks that have a heart for healing, somebody who's got a heart of compassion, a heart for mercy for their community. There's no need for formal mental health training. The training for the program is brief. It's actually just 2 4-hour sessions. And we're not trying to train mental health professionals. What we're actually trying to train is an informed community that can lead discussions and lead support well. The participants in the program are recruited through flyers and word of mouth. We use the terms need for trauma healing, that there's been some degree of trauma exposure, and that folks have some very tangible reactions to that trauma, some form of re-experiencing or some form of trauma-related avoidance. The groups meet for 6 weeks, 2 hours each, separate groups for men and women, and the clinical team that's with this is behind the scenes, and they're supervised on a weekly basis. The program structure shifts over time to really focus initially on the impact of trauma on one's life, and then moving to reconciliation with others post-traumatic growth. And the session structure includes some time for community, spiritual preparation, prophet narratives and discussion, so Ayub, Yusuf, and with doing the prophet narratives, we're really thinking about it as a role of cognitive restructuring, kind of challenging some beliefs that are there in a way that is very profound and real in somebody's life. And then using individual time, turning to Allah and dua. And this is really conceptualized as exposure to the trauma memory. And so we're giving very specific instructions about what the dua should look like. And then all sessions end in a closing supplication. We have published some initial pilot work that's in the journal Societies. And the US pilot data is actually looking really encouraging. We're seeing good results from pre to post group for trauma-related problems, depression, and for well-being. And this shows you a little bit of the effect size. The sample is a small sample at this point. But what I want you to see is that these effect sizes look like, and if we benchmark them to, they look like what we actually see in psychotherapy trials for individual psychotherapy. So we're really finding this initial data at least being very encouraging and well received within the community. We're at the point right now that we have funding from the National Institute of Mental Health, and we're doing a randomized control trial. And Mohamed Roble is going to come up and talk a little bit about the leaders that are working with us on this randomized control trial and their perceptions of the program.